Okay, I'm going to try to do this quickly because looking around, my sense is that people are starting to suffer from a little bit of T-wave inebriation. So let's run through this quickly. You like that? Good joke. All right. So this is the ECG, or one of the type of ECGs you've seen over and over and over again this morning. Dr. Merrick has quite appropriately told us that big voltage in isolation is not concerning, but big voltage, when it's coupled with repolarization abnormalities like these T-wave inversions in the anterior leads, and I'll just throw this out there. In my institution, we refer to leads V5 and V6 as apical leads, not lateral leads. It's a slight difference, but that's actually where the leads are located with respect to heart anatomy. So I would term this anteroapical T-wave inversions, but also ST segment depressions here in the inferior leads. So this is obviously a young man with a markedly abnormal cardiogram who has apical predominant, which is different than apical variant. Apical variant refers to hypertrophic cardiomyopathy where the thickening is confined to the apex. Apical predominant refers to thickening that's most pronounced in the apex but also involves other portions of the heart, probably different prognoses. So again, we use the term apical predominant quite deliberately here. As you've seen several times before, this is the list of normal, abnormal, and borderline ECG findings as presented by this most recent document. And of course, the first two things on the list here are T-wave inversions and ST segment depressions. But as you've invariably gathered from lectures previously this morning, T-wave inversions also show up on the, quote, normal ECG finding list with the two most common normal variants that we've talked about in some detail this morning, the so-called juvenile variant and then the African-American, Black African variant. So let's look quickly at the text here that defines ST segment depression. Again, the definition as proposed in this document is ST segment depression below the isoelectric baseline of greater than 0.5 millimeters in two or more contiguous leads. The text makes it clear that this is not a feature of athletic training in any way, shape, or form. Again, it must be in two or more leads, and the first follow-up assessment test here to rule out structural heart disease would be your transthoracic echo with a very low threshold to proceed to cardiac MRI should echo be in any way, shape, or form suboptimal. Here is the example of ST segment depression as pulled from the paper, and you can see here blown up on the lower right of your screen what this looks like. I've drawn a red line across the isoelectric baseline, which is defined by the TP segment, so the segment in between the end of the T wave and beginning of the P wave, the electrical time of silence that separates cardiac impulses, and then the ST segment here drops below that line in this example in V6. Most of the time when we talk about ST segment depression, at least in the general cardiology or internal medicine world, we're talking about ST segment depression as it relates to the exercise ECG, in which we know that different configurations of ST depression, when coupled with clinical factors, help you define a pretest probability of underlying coronary artery disease. And so there are three basic morphologies of ST segment depression: upsloping, horizontal, downsloping. We really don't have any well-developed concept of how these inform our risk of underlying structural disease on the resting cardiogram, but that's actually probably something we should start thinking about. One of the most important things to remind you about with respect to ST depression is exactly when in the ST segment it's measured, and by convention it's done 80 milliseconds after the J point. The J point is the final deflection of the QRS complex, so when you're trying to quantitate ST segment depression, that's the place in the ST segment to make that. Pathophysiologically, what causes the ST segments to drop? Well, the classic example is that of ischemic heart disease, in which the endocardial, or the inner surface of the heart, is relatively starved for oxygen, and in doing so, these cells become dysfunctional. These dysfunctional cells partially repolarize and thereby set up an electrical gradient from the outside of the heart to the inside of the heart. And this allows an electrical current to be generated outside of the normal timing of the cardiac cycle, and when this is picked up on the surface electrocardiogram, it shows up as ST segment depressions. Now, in the context of a big, thick heart that's just sitting there and is not clearly ischemic, why would ST segments develop? I think there are some interesting theories around this. The jury's still out, but probably what's happening is there are repolarization heterogeneity zones occurring where there's mild flow of current just in the resting heart, but again, that's an area that's not particularly well understood. What about T-wave inversions? A little bit more complicated than ST segment depressions, and you can see here in the document that T-wave inversions are really defined as a function of their territory on the electrocardiogram. And I won't belabor this because you've seen this in detail, but the text again defines T-wave inversions as greater than 1 millimeter in depth off the isoelectric baseline, and again needs to be in 2 or more contiguous leads with the exception of AVR 3 and V1. That means that T-wave inversions in 3 plus only 2 or only AVF does not constitute an abnormal finding, that you need them in multiple ones, and we'll talk about that in some more detail. And then again, there are reference to these normal variants, which include those in black athletes and in younger people with anterior precordial T-wave inversions. Here are examples from the paper of the so-called juvenile pattern and the black pattern, and I just want to say a few words about these, which kind of move above and beyond what's in the document, but are a little bit more of a personal perspective around this. This was shown earlier by Sanjay, some work from our group in which we looked at the distribution of anterior T waves in young, healthy rowers. Now, these were people that were above the age of this 16-year-old cutoff, but what we found is that in 1% of these people, they had T wave inversions out to V3. And all of these people had a similar attribute, and that is that they had delayed R wave progression. So we label things based on specific leads, but I want to remind you that specific leads are a function of placement and are a function of physiology. So oftentimes in well-developed endurance athletes, as you heard from Dr. Sharma this morning, one of the things that happen is they dilate and enlarge their right heart and shift the electrical vector off to the side. And so what this looks like on the 12-lead electrocardiogram is often a delay of the QRS transition. And remember that T waves and QRS vectors are concordant. So if the net QRS vector is down, the net T wave vector should be down. So when we talk about where T wave should go from being down to up, instead of focusing on leads, I would encourage you to also focus on this issue of RS transition, which unfortunately wasn't captured in this document. With respect to the African variant, Sanjay and his group have really taught all of us about this. I was delighted, Sanjay, to hear you earlier admit with some transparency that you're not 100% certain that we should categorically label this as truly benign. And that although there's lots of good follow-up, I think some folks, I will speak for myself, have been reticent to consider this truly benign without any possibility that this represents some risk factor. But indeed, the vast majority of people that have this finding on their surface electrocardiogram will go on to have normal athletic participation with safety. And so I think for the most part, this is not something to be concerned about. This pattern bothers me the most, and that is these T-wave inversions that are following isoelectric ST segments that are really all over the cardiogram. And this, in my mind, is probably the most highly specific T-wave inversion pattern for underlying structural heart disease. This is the one that probably in 50 to 60% of the times you find it is going to really show you that there's something bad underneath the hood of the car. And there it is. This is an ARVC case. So what to do about these things? I mean, I think we're all at this point quite familiar with the fact that ST segment depression and T-wave inversions should raise concern for underlying structural heart disease, and the list of diseases that come with these two findings overlap quite dramatically, and you can see them here: hypertrophic cardiomyopathy, dilated cardiomyopathy, left ventricular non-compaction, arrhythmogenic cardiomyopathy involving either the right or the left ventricle, and of course acute myocarditis. The evaluation here really focuses on imaging, with echo being the gold standard first line therapy, and then a very low threshold to proceed to more definitive imaging should the echo be not 100% perfect. And then we haven't talked at all this morning about exercise assessment, and just to plug in there to exercise your athletes if in doubt, and remember that exercise in athletic patients should be done to maximal volitional fatigue. No terminating people at a preset heart rate. Let them go as hard as fast as they possibly can, and let them, if possible, participate in an exercise test that simulates the type of sport they do on the field. It takes some creativity, but it almost certainly increases your diagnostic yield. So a couple of just ST segment T-wave inversion things to take away that are my personal perspectives. I think Sanjay and I got to the same conclusion in going down the same path independently, that is, isolated inferior T-wave inversions have very, very low specificity for disease. Regardless of whether an athlete's white or black, when I see T-wave inversions without ST segment depressions in 2, 3, and AVF, I begrudgingly end up doing imaging, but I never find problems. And so I suspect that as more data accrues, this will be one of the things that gets moved into the benign category. If I'm wrong, I'm happy to accept that, but that has been my experience. With respect to this issue of isolated anterior T-wave inversions, and I would submit this is a function of both black and white athletes, that although it may be convenient, it's oversimplistic to label leads. Think about the RS transition, and if T-wave inversions persist past the RS transition, then they are much more likely to indicate pathology than if they invert at the time of the RS transition. That last ECG I showed you, so diffuse T-wave inversions with an isoelectric ST segment, this in my experience is highly specific for underlying disease and should never be ignored. And then finally, something that started to come up indirectly over and over this morning is this issue of what to do in an athlete that has an abnormal ECG but has an initially unrevealing workup. I think the only mistake you can make is to give this person a false reassurance that they are going to be healthy and normal forever. And these are the people that we need to do due diligence around and follow serially. And indeed, we have a lot of work ahead of us to figure out the exact optimal imaging timeframes, what type of testing should be done, but what I think we can say quite convincingly at this point is that these people need not be sent off into the world and reassured that they're going to be good forever, but rather followed clinically to make sure there are no problems that evolve. I will conclude with that. Thanks so much.